Good morning, everyone. Welcome to the U.S. Agency for International Development's One Health Workforce Project ECHO Collaborative Community of Practice session. This morning, we are just thrilled to have you join us to discuss gender and psychosocial issues that we're facing in COVID-19. And I'd like to introduce you to Dr. Bruce Struminger, the lead of Project ECHO, and the wonderful platform that we're using this morning for a few tips.
Great, thank you, Jonna, and welcome everyone. Got a really fabulous session coming up for you. I just want to go over a few logistic items. As Jonna said, we're building a community of practice, a virtual community of practice, and one of the really important things is being able to see each other as if we were in person. So this technology allows us to turn on our camera and be face-to-face, even if we have lots of miles in between us. So if your bandwidth allows it, please turn on your camera and join us face-to-face for this learning session. We really want your camera on, but we also want your microphone off if you're not speaking. So try to keep your microphone muted during the session unless you want to add a comment. If you can, please rename yourself with your name and the name of your organization so we know who you are and what organization you're with. That helps us build our community of practice. And if you've got any IT problems, chat ECHO IT, and they will try to help you resolve those. In the chat for everyone, we'd love to see you put your questions and comments. We don't need you to put your attendance or say you're here. We're tracking and tracking the attendance through Zoom, and we're also trying to encourage everyone to use the PDA participant app. The download link and the instructions were in the announcement. We will also put those in the chat. And this is an app that we're piloting that will give you a certificate of attendance. In order to get that, you need to have the app and then scan the QR code that I've put up to the right here. And then at the end of the session, toward the end, we'll put up another QR code that's the end QR code that you'll need to scan out. And when you do that, you'll instantly get access to all of the PowerPoint presentations of our speakers today. I was able to upload all of them. So you'll instantly have those. You'll be able to share those with your colleagues and friends by WhatsApp or email, and you'll get a mobile certificate. So please do that. I will also stay on if I can for a few minutes to help troubleshoot if anyone's having challenges. All the presentation slides will be shared by email, as well as a link to the recording. At the end, probably within a day or two, we'll send that email out. This session is being recorded, and your attendance is consent to be recorded. Thank you for that, and thanks for joining us today. There will be continuing professional development credits through the University of New Mexico. We'll share a link about 15 minutes before the end of the session. You'll need to complete a brief survey. It takes about 2 minutes. That gives us valuable feedback so we can improve these learning sessions and make them better. And you'll get an instant certificate of continuing professional development. There's a social media guide. We'll put a link to that in the chat. It's here, but we'll put that in the chat as well. So if you're tweeting or twittering or doing Facebook or any other kind of social media, there's some good tips in that. For our Francophone colleagues, there is interpretation. So down at the bottom of the Zoom bar, you'll see an interpret little globe. And if you click on that, you'll see a French line. If you click on that, you will hear French. So please take advantage of that. We will have one French presentation toward the end today. The Anglophones will stay where they are, and we will hear the interpretation in English. So you don't need to shift when our Francophone colleague is giving her presentation. So with that, I'm going to stop and turn the mic back to Jonna. Thank you.
Wonderful. Thank you so much. Thank you, Bruce, and the whole Project ECHO team. And thank you to all of you who have joined us for multiple sessions in this community of practice around COVID-19. We recognize that everyone is facing different stressors and different circumstances. Some have lost loved ones. Others are really suffering from the isolation or the disparities in the way that we are sheltering. In the academic community, of course, we are also faced with a lot of challenges, including questions about facts versus people's feelings, and questions, and potentially even damaging controversial theories about things around COVID-19. And all of these things contribute to the potential for, and now definitely what we are seeing in depression and stress related issues that are going to continue while we're sheltering, but also after, from the trauma of this event. So I welcome you. I thank you for joining us and being together so that we can get through this together and learn and be resources for our community. And with that, I'd love to hand it over to my partner from the African One Health University Network, Professor and Dean William Bazeyo.
Thank you, Jonna. And as just to join you, I want to welcome our colleagues. I want to welcome everybody that has come on. And it is exciting that it has been persistent. We have had people come, discuss, and then I'm sure those who listen, there's a lot that we have learned and we have taken back to our institutions and our countries. I must tell you that what Jonna has said, it is very evident in many communities. Many communities have suffered. We have suffered as professionals, answering different questions. But also, I think our governments have had a lot of challenge maintaining people who have several questions, who say, I'm not sick, why shouldn't I work? How can I stay at home for all this time? And because of that, there are those who were earning on a daily basis. It's a very big challenge. You find that the family has been depending on one provider who earns per day, now earns zero. Even if there are food supplements and the distributions, of course, they cannot be enough. But one thing that we have learned is that if people change their behavior, then they're able to manage, or they're able to go through certain circumstances. This situation has also made us learn that change of behavior, as we always study, that it is hard, but I think it is not very hard. As long as there is a fear for something, people tend to change their behavior. But what we have noticed is that after the president's speech, and he opened up some few places to work, people who had behaved so well, some of them said, no, this is too much, and they got out to become rowdy like we have seen in some cities. I must say that one of the things that we have learned, and I think we should take to our communities, is that we need to tell our communities how this disease affects them, how they get it, and how they can avoid it. Saying prevention is not enough, but also to educate our communities. How can they identify an individual and say, here you may be sick? And how can they, or how can we have our communities police each other? How do we police one another in our communities? I think this is a great lesson that we need to learn. We have not had it before. I must admit, many diseases that have come and many epidemics have not taught us, the whole world, how do we police each other and how do we help each other. Lastly, I would like to talk about, and I don't know whether this is common in our societies, in all the societies, we have noted that People who are vulnerable are those who are always on movement. People who are separated from their families for a long time, they are more vulnerable than those of the same age bracket, but who are working and staying at home. I think as professionals, we need to come out with some method of training, some method of sensitizing our people who are always on travel. Truck drivers, people who travel long distances, and I'm sure if we had the flights moving, we would have to sensitize some of them. So my sincere request to everybody on this call is, how do we develop a mechanism to protect our people in the communities, or people who are always on move and they come back and meet these communities that are normally stationed in their workplaces or their homes? How do we sensitize them so that we can make a difference? With those few remarks, I'd like once again to welcome everybody and thank our speakers who agreed to speak and give us their wisdom so that we can listen and then we go home with some lessons to take back. Thank you very much. And thank you once again, ECHO, for organizing this. Thank you, Woutrina. I thank Jonna. This is marvelous. I think if we do not learn anything from this partnership, then we shall have missed the whole thing. But I believe that our supporters, our funders, USAID must be excited that we have such a partnership that can bring as many as more than 100, 150 people together to discuss one single topic every week, every other week, to see how we help our communities. Thank you very much, and thank you, Marilyn, I'm sure you are there. Thank you for supporting us and everybody else. Thank you, all of you, and I wish you good listening and learning this afternoon and this morning on your side. Thank you.
Thank you so much, William. With that, we'll move over to our great outbreak lead, Dr. Brian Bird, for global updates on COVID.
All right, thank you very much. It's great to be back with everyone. We've been doing this for several weeks now, and I'm very pleased and excited to talk with you again and give you the global picture update of things that I've come across in the last 2 weeks, and a few interesting tidbits and links to important information that I think will help us all understand this global pandemic a little better. And just now, in the past 2 weeks, we're starting to get more sequence data of the virus from the continent. And this is, again, a map from nextstrain.org. If you're interested in the genomics of the virus, please check that out. But you can see a lot of virus movement in and out of the continent coming down from Europe and the US and from Asia.
Dr. Bird, we're not seeing your slides. Do you want to share screen?
Oh, hang on. Sorry, guys. Ooh. Zoom. Oh yeah, you have to do that first. Yeah, right.
But the buffalo looking over your shoulder is also very
exactly. Great. Yeah. Okay, now we should be in business. Yeah. See my screen now?
Yeah, go ahead and do presenter mode now and you'll be all set.
On it now. There we go.
Presentation mode.
Aha.
Yeah.
So now you can see the map. Check out nextstrain.org and everything will become quite clear. They do a great job of explaining the genetics and how the viruses are moving around the world. Then, okay. So from the last time we spoke 2 weeks ago, there are almost 1 million more cases of COVID-19 around the globe. We're now at a little over 3.5 million cases. So the pandemic is increasing in virtually every country for the most part. Some countries are doing a nice job controlling it. And it's nice to see that so far our laboratory confirmed cases across the continent and especially in the AFROHUN network countries remain quite low at only about a little under 6,000 cases. But I want to draw your attention to the graph on the right, which is from Africa CDC. And this shows the daily increase in cases reported by the region across the continent. So while in your country and in your local area, things might be quiet right now, please take great care Do as Dean Bazeyo said, think thoughtfully about how you're interacting in your communities and your environment to ensure that you're acting in a safe way, because the virus is there. It is transmitting through our communities. In the past week, a very nice resource came out from the World Health Organization with contributions from IFRC and UNICEF. And this is a guide to community-based healthcare. It includes sections on outbreak responses and health communication campaigns. And we've talked about that quite a bit in previous sessions about our community-based surveillance and other things. So please look at this document. It's quite extensive and has very nice decision tree algorithms and other things that would be very helpful, I think, as you work through how to deal with the pandemic with your local healthcare systems and ministries of health. Also, just wanted to touch on, there's now more and more information about the economic impacts, and thank you, Dean Bazeyo, for really highlighting that and how people that are on lockdown really are in a struggle, as we all are together, in thinking about how do we feed our families, what will our job future be like, and how will we allocate healthcare resources. And this is very vital when we think ahead towards vaccination campaigns for like the childhood illnesses and things. Like, how will we pull that off and still protect the young ones while we're still trying to protect everyone else from SARS-CoV-2. Okay. And then, sorry, I'm having some, now there we go. There's another resource that I think we should check out, because we're not in this battle alone. I know sometimes we're on lockdown, we only see the same faces every day, except when we're on an echo session or chatting with people online or on the phone. But if you go to the link on the right, biorender.com, there's a wonderful tracking tool now about all the multiple vaccine candidates and therapeutic agents that are in development. And just in the last week, the European Union received pledges of over 7.2 billion euros to develop more extensive human testing of these novel vaccines. And here's just another screenshot from that. I really recommend you go to that link. It will be in my presentation. Just click on it and it'll take you straight there, and it'll show you all that you would really want to know about the vaccines and the drugs in development. And again, my last slide, as always, is just links to all the information that I've talked about up above. Thank you very much. I'm very excited to have a great panel this week. One of my close colleagues, Dr. Sabra Klein, I learned so much from her when I was a younger scientist, and I think you'll really enjoy her presentation because she is truly marvelous. Back to you, Dr. Mazet.
Thank you. Well, as we know, and from Professor Bazeyo's wonderful intro, we are very excited to have these wonderful presenters, and I'm thrilled to introduce to you my colleague who leads our gender equity program for the One Health Workforce Next Generation. So Professor Ndola Prata, we couldn't be in better hands, and we're so excited to hear from you and the panel.
Thank you so much, Dr. Mazet. It's a pleasure to be the moderator for the session today. We know that assessments of risk, prevention, and response to outbreaks must incorporate the lessons learned on the significance of gender in the spread and control of epidemics. And our panelists today will speak to the significance of sex and gender during epidemics. So without further ado, I would like to introduce our first panelist, Dr. Sabra Klein, Professor of Molecular Biology and Immunology at the Bloomberg School of Public Health at Johns Hopkins University. Professor Klein, welcome.
Thank you so much. I'm so honored to be here. And let me share my screen. Okay. I'm sorry. Let's see if I can go back. Okay, so I am honored to be speaking with all of you today. While much of the focus of this session will be on gender and the psychosocial aspects of the COVID-19 pandemic, I would like to talk a bit about our biology and the biology of sex differences and how this can impact not only how the outcome of COVID-19 infection, but also possibly treatments, as Dr. Bird was describing to us. So before I enter into worldwide data, I would just like to take a moment to clarify some terminology. In 2001, in the United States, the Institute of Medicine published a report entitled "Exploring the Biological Contributions to Human Health, Does Sex Matter?" And in this report, they operationally defined the terms sex and gender, which should not be used interchangeably, but are actually quite complementary as we try to better understand the differences that exist between men and women, with sex referring to our biological differences associated with being male or female according to our reproductive tissues, such as our ovaries or testes, as well as our sex chromosome complement. And this is in contrast to gender, which refers to ourself as being either male or female, a man or a woman, as based on the societal or cultural norms that can come with that and that we all respect, can also differ by country. My colleagues and fellow panelists will be speaking extensively about gender. So I will refrain from extensive discussions about gender and focus more on sex as a biological variable. This is a variable that affects our immune response. So as everyone on this Zoom call knows, men and women differ in their sex chromosome complement, with women having two X chromosomes, or I should say females having two X chromosomes, and males having an X and a Y chromosome. On the Y chromosome is the SRY gene, which encodes for testis determining factor and contributes to the development of what would be during development a bipotential gonad. It allows this gonad to develop into a testis. In the absence of this signaling, we have development of ovaries. The ovaries secrete high concentrations of estrogens. The testes secrete high concentrations of testosterone, resulting in a difference between males and females in circulating concentrations of sex hormones. These hormones can bind to their receptors to result in sex-specific responses, including sex-specific immune responses. This is true for both our innate and adaptive immunity, as well as the development of inflammation and even autoimmunity. In addition to hormonal effects, there can be genetic effects, including contributions of X-linked genes. There are over 60 immune response genes located on the X chromosome. There are also sex differences in the expression and activity of autosomal genes, primarily through epigenetic mechanisms. So when I say sex, and I refer to sex as a biological variable as we discuss data from the current COVID-19 pandemic, these are the underlying mechanisms that are contributing to some of the biological differences that can exist between males and females and impact how we respond to an infectious disease. What we're looking at in this world map are data collected from the Global Health 50/50 organization. They are doing a beautiful job, and I have a live link here presenting data from around the world pertaining to disaggregation of data for men and for women. What we see here, countries that are in green, including some countries in Africa that are currently not disaggregating data to compare males and females in either cases or fatalities. In brown are countries that are, in fact, disaggregating their data between males and females. This includes countries such as South Africa. And South Africa has been particularly good disaggregating both cases as well as deaths from COVID-19. In yellow or orange, we have countries that have partial sex disaggregation, so they may be disaggregating cases but not deaths, or vice versa, deaths but not cases. And then finally, in these stippled lines, in the either orange countries or the brown countries, are countries that are not only disaggregating data for the entire population, but are focused specifically also on healthcare workers, knowing that approximately 70% of the worldwide healthcare force are women. So what we see from the data from around the world collected here for COVID-19 cases is where I would like to begin, is that approximately 34% of the countries that are disaggregating COVID-19 cases are reporting a male bias in those cases, whereas 45% of countries disaggregating data are reporting a female bias, and 21% of these countries are reporting no bias. This is based on reporting from 44 countries from around the world, including Africa. When we look at COVID-19 deaths, this is where we start to see a very stark bias, in which 87% of countries disaggregating COVID-19 deaths are reporting a bias in males. So significantly more males are dying from COVID-19. 11% of these countries are reporting no bias, and only 2% are reporting a female bias. This bias, this incredible male bias or male risk for more severe outcome from COVID-19 is something that I would like to delve into a little bit more deeply. When we look specifically at individual countries, which are located here in panel A on our y-axis, and we're looking at the case fatality ratios within each country, females being pink, males being blue, what we find is that whether these are countries with a great number of cases, such as Italy or the Netherlands, where we see significantly more males dying from COVID-19 than females, or if it's a country that has had significantly fewer cases, such as South Africa, regardless of the numbers of cases, the male bias exists. Being male is in fact a risk factor for more severe outcome, including death from COVID-19. There are countries that have not only disaggregated data by sex, but have also disaggregated data by age. And if we look at the case fatality ratios collapsed across these countries, and we look at 10-year increments ranging from infants all the way to individuals 90 years and older, again, males blue, females pink, what we find is that there is a dramatic increase in case fatality rates according to age, with the majority of the deaths occurring around the world among individuals 70 years and older. But what we still see beginning at age 30 onward is that within each of the 10-year age groups, males are significantly more likely to die than females. So we're even seeing that with advancing age, this male bias still exists. There are several possible mechanisms for both sex and gender differences in COVID-19 pathogenesis. My colleagues on this panel will speak about gendered variables as well as even comorbidities. So what I would like to bring your attention to is the fact that there can be genetic and even epigenetic differences between the sexes that can impact outcomes of infectious diseases. I mentioned sex hormones like estrogen, testosterone, both of which are known to impact not only our immune system, but the receptors that the virus uses for entry into our epithelial cells. There are virological differences, including a presumed lack of ability to control viral shedding in males as compared with females, as well as growing evidence for sex differences in innate immunity, antibody responses, and T-cell regulation, all of which are typically higher for females as compared with males. Sex differences in the immune response to SARS-CoV, coronavirus 2, are becoming available. We are seeing increased documentation of sex differences in the expression of the receptors, including ACE2 and TMPRSS2, that are used for viral entry. We know, in which I should say that these receptors seem to show greater expression in males as compared with females in diverse tissues. There are sex differences in receptors such as toll-like receptor 7 that are used for virus recognition, both by innate immune cells, but also adaptive immune cells. There is evidence of sex differences in cell death, which is going to contribute to differences in the immune responses. These immune responses are a double-edged sword, being beneficial for control and clearance of the virus, but also contributing to vascular leakage and damage, which can contribute to severe respiratory disease, which is presumed to be greater for males than females. And I already noted for you that antibody responses are greater for females than for males. I have several collaborators, both at Johns Hopkins and elsewhere, including the Canadian Institute of Health Research. And I would like to give a special call out to my colleagues in the Gender and COVID-19 Working Group, an international group of investigators focused on the differences between males and females. So I thank you for your attention.
Thank you so much, Dr. Klein. I would like to invite participants to write in the chat box questions for Dr. Klein. We'll take some questions after the second speaker. So our second speaker is Dr. Brigitte Bagnol, and she is part of the Department of Anthropology at Wits University in South Africa. Welcome, Dr. Bagnol.
Thank you, Bagnol.
Brigitte, you're on mute. Brigitte, you are on mute.
Oh yeah.
Thank you.
Sorry. So good morning, everybody. Thank you for inviting me in this very important and interesting session on gender and COVID. And thank you for Dr. Klein for this beautiful presentation on the relation between COVID and sex. My presentation will focus specifically on gender issues. I'm going to try to show you, as well as sex influence the impact of disease on men and women, gender also influence the social and economical impact of disease on men and women. When we look at the situation, the current situation in different countries, we understand and we see that in relation to decision-making power, women have a very limited possibility to express their opinion and to have making decision power. By example, in Italy, women represent only 20% of the leaders involved in national responses. In the UK and the US, the pandemic security response team was or is still entirely men. So this situation allows us to understand that women have been marginalized in the response and the decision-making around the response. This has, of course, consequences because as the UN Women is calling attention on this aspect, the response is not gender sensitive. Women are not involved, women's organizations are not involved, and some of the responses might increase the gap between men and women, might increase inequality between men and women, And we have evidence showing that, by example, confinement increased gender-based violence. My previous colleague also already mentioned this aspect. We see that women have a very, very important role in healthcare, both at home and in the health facility. Women represent 70% of the health staff and 90% of the nurse. However, they are often in a very low position and a low salary compared with male in the institution who have a higher position. Often, people who are working in health facility work in understaffed situation, under-equipped, and they are often overexposed to the virus. In the houses during confinement, women assume an increased domestic and caring role. They are caring of the children, they are caring of the sick, they are caring of the elderly, and often without training, without preparation to do that. Gender-based violence has been increasing in most countries. Here I'm presenting only data from France, where I'm from, that says that in the following 2 weeks after confinement, it was possible to register already 36% increase in report of domestic abuse. So this shows the huge impact of COVID-19 on women in terms of increasing role in the household, increasing role in the health domain, increased gender-based violence, and finally, increased financial insecurity. We know that in the world, women are more likely to have insecure jobs, have positions who have very low pay, work with informal job, and they are very likely to lose their source of income due to lockdown and economic crisis. So in front of this situation, I would like now to discuss some of the recommendations to integrate gender in the response to COVID-19. And those recommendations have been developed based on previous experience on Ebola, on other pandemic like avian flu, and even on HIV/AIDS. The first recommendation relates to the disaggregation of data. And my previous colleague already stressed this aspect. Data needs to be disaggregated by sex. Some countries are still not doing it. And in addition to disaggregate by sex, we saw that it's very important to disaggregate the data by age. And information also that we have collected until now show that there is a lot of disparity in deaths according to the social group people belong. Data from UK show that in the poorest group of people, the mortality can be as high as twice as the mortality in the richer group or class of population. So it's important to analyze and to collect data disaggregated by sex, by gender, and also according to age and according to social characteristics, because we know that those differences might have a very high impact in the outcome of the disease. We saw that women are excluded from decision making, so there is a call to improve gender-sensitive programming and response to the pandemic, and to involve as much as possible women organization in all the phases of the prevention, the response, the mitigation activity, and even in public discourse. And for this, it's necessary to support women's organization, because due to their role in health facility and in the home, they can positively influence and design intervention. Another recommendation is related to the healthcare. As we saw, women are very important in providing healthcare in health facility. So it's necessary to value their activity, to value their role, and to give them safe and decent working conditions, and often a better salary. Our experience from previous pandemic like Ebola or Zika indicate that when health attention is concentrated on the pandemic, it's very likely that other services are left a little bit behind. And this has also very negative impact on women's sexual and reproductive health. So as a recommendation to do gender sensitive intervention is to have a specific attention on those services and to give continuity of provision of service and care. As mentioned also earlier, due to the increased gender-based violence observed during the pandemic and specifically lockdown, it's very important to make gender-based violence services available, known by the people, and updated to the condition of the lockdown. So different mechanisms need to be put in place to ensure that men and women who are suffering from gender-based violence can access them. Mental and psychological support is necessary. I think my colleagues are going to speak a little bit about that. We see a lot of situations of stress, depression, boredom, fear, anger, and all those mental situations need to be taken care of, and psychological support need to be put in place. In relation to education, gender sensitive intervention should try to mitigate the negative impact of keeping children in the home, create radio, television, and education programs for children to help them to continue to study and to allow for women to have some time and space to take care of other aspects of their life and the household life. Also, the importance of taking care of the financial and psychological support of households with disabled children need to be taken in consideration. And many countries have done it to give support childcare for working mothers. As we saw, a lot of women are working in health facility and they need support for caring for their own children. Due to the situation and the need to have an improved hygiene, it's very important to ensure access to safe and sufficient water and sanitation for any hygiene need in the household and also in the workplace. As we said, in addition to be a health crisis, this crisis is also an economic crisis, and the poorest marginalized group of people are going to suffer the most. So special attention should be given to people who are already or were already vulnerable and are going to become even more vulnerable, such as undocumented people, homeless, the poorest in this different society, and marginalized group. And support can be in form of information, shelter, food, and specific health care. Many countries are also trying to give food and voucher or cash transfer and subvention to a different group of people who are very likely to become vulnerable or during the pandemic. It is important in this case to try to make women the beneficiary of those voucher or those cash transfer, because we know that when women receive money, they are more likely to invest this money in healthcare and nutrition or in their household. Another recommendation for gender-sensitive intervention is to develop or to set up a moratorium on rental areas, on the disconnection of public services such as water, electricity, telephone, or internet, because we understand that is very, very important in this period for maintaining social relationship. In addition, it is also important, and this has been done in very many countries, to ask companies to allow staff to work from home without penalty and keeping on their salary and their benefits. And this is the end of my presentation, and I thank you for your attention.
Thank you so much, Dr. Bagnol, for this very important recommendations. So again, if you have questions for Dr. Bagnol, and I see some questions for Dr. Sabra, please put it on the chat box. Yuta, I'm gonna ask you now to launch the question. So you will see a polling question. Please answer this question, and then we will discuss, so we will see the results during the next session after the next two presenters. Now, a question for Dr. Sabra, coming from it's related to, so if males have, the reason why males have more, the contributing factors for differences in mortality, do you think that this is associated with their behavior, or because males tend to take illness less seriously?
Absolutely. I think that that would be an example of a gender-related factor that I think is very important. There are data that men are significantly less likely to seek out healthcare, even when available, and delaying seeking out care if somebody suspects they may have COVID-19, that could absolutely increase the risk of this becoming more severe. So I do think that is a very important observation that you've made.
Thank you, Dr. Sabra. Dr. Bagnol, there are some questions related to the increase in the gender-based violence. Do you have any recommendations with respect to how, for example, services should be part of the essential services during this lockdown?
Thank you for the question. I think it's very important because the situation has been observed in many countries. I think that what countries are trying to do is to make the information available to most of the people via television, via radio. They establish new red line or new telephone number where people can call. They involve pharmacists, because most of the people are allowed to go to the pharmacy. They involve pharmacists, they involve people in the neighborhood and the NGO to try to support the possibility to give intervention, to give support by telephone for people who are suffering for those gender-based violence.
Thank you so much, Dr. Bagnol. So I will introduce now our third speaker, Dr. Florence Muhangazi. She's a senior lecturer at the School of Women and Gender Studies in the College of Humanities and Social Sciences at Makerere University in Kampala. And we will close the poll now. Thank you.
Hello.
Yes, Florence.
Hello. Thank you very much, Professor Ndola. Can you hear me? Hello?
Yes, we can hear you. We can hear you. We can hear you.
Okay. So thank you very much. I'm very happy to be part of this panel to discuss this important topic. I'm going to delve more into the gender realities of COVID-19 and look at that are coming up because of the pandemic in Africa. My colleague has already looked in detail about how COVID-19 is affecting the world and has given most of the current statistics. And so I'll not go so much into the details of the statistics, but we know that Africa was like the last continent to have the cases of COVID-19, and Egypt was the first African country to have a reported case. That was in February, and then Algeria followed, and then Nigeria, and then the rest of Africa. And since that time, then we had WHO declaring the outbreak as a global pandemic. And that's when most of the African countries now went into thinking about strategies to try and deal with the epidemic. And so as my colleagues have already alluded to, sex disaggregated data of the countries, especially in Africa. We see South Africa giving us the statistics, Algeria and Uganda, and we see more males dying than females. And my colleagues have already looked at some of the sex-related vulnerabilities as to why we are having more men dying than females. And so I will not go into that, but rather to look at the other aspect of gender, where here we have gender as a melody world over is an important aspect in COVID response, because gender creates hierarchies. It defines who does what. It defines the entitlements in terms of access to and control over resources, and also the influence on power dynamics, which often position women and men differently, relegating women and girls to a low status, and which increases their vulnerability to the impacts of such epidemics. So beyond the health aspects and looking at COVID-19, beyond it being a health issue, there are other social related impacts that we are seeing that we are seeing that are impacting on men and women differently. The gender norms and social norms and beliefs around around who women and men are influence the health-seeking behavior, the roles, the gender division of labor, and the roles that are being played in the response. And so, as my colleagues have already alluded to, we know that women take the biggest share in the care. In the care, we have seen women taking a leading role as frontliners, and looking at some of the interventions in most of these countries, in the national response where presidential COVID task forces have been put in place to guide the pandemic. You find women taking a leading role. If I can give an example of Uganda, where we have seen women really taking the front, leading the response, and we are seeing good results from that. But unfortunately, globally, you find that women's representation, especially on the NASA spaces, quite few. Going to the healthcare generally, in Africa, women, and they are the ones who are doing most of the responding to taking a lead. Brother givers, the majority of the caregivers in our communities at home are women. Families, particularly food provisioning, caring for the sick, that women have increasingly taking over even the breadwinning role in their families, in addition to the caring roles. For instance, in Uganda, women do twice more hours on unpaid care than the men. And so if you add in now the burden of where every is at home, definitely the care, the burden of care is much higher. Look at food provisioning, which is over 50% of the women in Africa in selling food. And all of this is happening amidst inequalities in our societies. Women are experiencing a lot more of challenges associated with COVID-19 as an epidemic, which most of the response mechanisms do not take into account. As my colleague has already alluded to, most of these approaches are gender blind and therefore do not take into account some of these care and important roles that women do. And now moving into what countries have done in order to address the epidemic, because of the circumstances that we are in Africa, high levels of poverty, overcrowding, most of the lockdown, stay home, stay safe, and social distancing, suspension of public transport, businesses, those that they named as non-essential services, which at the end of the day has had a significant impact on especially vulnerable groups, on especially those that live on day-to-day, income, most of whom are women. Although there has been support in terms of provision of food relief, in some countries, a few of them have provided sanitary facilities and water. These have come with a lot of challenges, not reaching especially the vulnerable. And because the measures were taken in panic without adequate preparation, and therefore governments were not able to put in place contingency measures to support the vulnerable groups. And they are now coming up realizing that some of the things need to be taken into account. And so a lot of challenges have been experienced as we go, as we go through this. And so COVID-19 has been looked at more in the negative, but there are some voices that point to positive aspects where some are seeing it as an opportunity for strengthening family bonding, where parents have gotten now time to be with their children, teaching them skills, helping them with holiday work and the like, and the like. But of course, relief from stress. But amidst the complex situations of poverty, the reverse has been true for some families, especially those in poor resourced settings and other gender-related constraints. And so, for instance, you find that there is evidence that there is a lot of joblessness because most of the hello.
Yes, Florence, we can still hear you, but we understand you're having some connectivity problems.
Internet problems. Can you hear me now?
Yes, yes. Go ahead.
Can you hear me?
Yes, go ahead, please.
Oh, okay. So I was saying that the stay at home stay safe campaign has created a lot of challenges related to loss of income for majority of the women who work in the informal sector. And so on daily earning, and we know that globally over 68% of the women are in the informal sector. We know that in Africa 62% live in the informal sector, and of course these statistics vary across 85. Closing down businesses has meant a lot. They are provided food. This has not. These have talked about the spike in gender-based violence. This is real for many countries in Africa. It has been reported in Nigeria, in Ethiopia, in South Africa, in Kenya, and so it is a big issue that response mechanisms should take into account. The issue of the burden of care definitely is a real one. Care of children at home, the kind of thing is real, creating a lot of stress, creating issues of relations, and actually most of the gender-based violence is coming about because of lack of income, because of economic insecurity, because of food shortages. We see many
Florence?
Clips in the media of people of fighting women out, not being easy. The other impacts have been loss of employment. Yes. Hello.
Yes, Florence.
Hello?
We are having a lot of trouble. Florence, we are having a lot of trouble hearing you.
Hello. Hello.
Florence, can you hear me? Florence, we are having quite a bit of trouble understanding what you're saying. So maybe we can retake
Hello?
some of these discussions during the question and
Hello? Hello? I can hear you, but I don't know whether you can hear me. Hello?
Yeah, I think we're going to need to move on, but I would also suggest that we do an experiment for everybody, that we turn off our individual videos to see if by chance that helps with the connection for our speakers who are having some internet challenges. It's not quite clear whether that will make a difference for Zoom, but if people would like to try turning off their videos, there is a possibility it might help with the connection for the speakers who are having those challenges. We do need to move on to our last speaker so that we'll have a bit of time to have discussion, but we can certainly continue this beyond that going forward. Thank you very much for the wonderful presentations.
Jutta, can you stop sharing, Florence, so that Georgette can share her slides. Our next speaker is Dr. Georgette Ngweme, and she comes from the Health and Environment in the School of Public Health in the University of Kinshasa. Georgette, you are on mute. Do you want us to share your slides, Georgette?
Yes, ma présentation est là. Je ne sais pas si vous l'avez vue.
Non. Jutta, can you share the...
Alors, je vais essayer de partager.
Georgette, tu peux attendre un tout petit peu?
Oui.
On va essayer de notre côté ici.
OK.
Merci.
So Jutta, is your team sharing the slides for Georgette?
Yes. Connie, are you ready?
Yes, I have them on. Can you not see them?
No, we do not read the slides.
Okay, just 1 second.
Okay, we see your screen, but not the presentation yet.
Okay, just a sec.
It disappeared again. Sure.
Okay.
Okay, it's coming. Yes, there we go.
Okay.
Just we need presentation mode.
Yeah.
Okay.
Georgette, est-ce que tu peux dire quand avancer, s'il te plaît?
Are we see?
Je peux commencer?
Oui, oui.
OK. Bonjour tout le monde et bon après-midi. Moi, je suis le docteur Ngweme, doctorante à l'école de santé publique de l'université de Kinshasa. Alors, je vais dire un mot par rapport à la femme et le COVID-19 en République démocratique du Congo. Alors, mon pays, la République démocratique du Congo, c'est un grand pays qui a plus ou moins 2 345 000 km² avec une population d'au moins 80 millions d'habitants et c'est une population jeune. Alors, par rapport à la femme, nous avons une grande expérience en République démocratique du Congo par rapport à Ebola, où nous avons vu que des femmes sont capables de mener des mobilisations communautaires dans le cadre de la diffusion des messages pour la prévention, pour la gestion des cas et pour la lutte contre la stigmatisation.
Excusez-moi, on peut pas...
Et ils sont aussi capables dans les différentes réunions, dans les églises, en famille, de promouvoir des gestes barrières. Nous voyons les slides qui suivent, comment la dame est en train de sensibiliser les autres par rapport à des mesures barrières que mon pays a dit instaurer.
Excusez-moi, les interpréteurs
sont capables de transmettre l'information par rapport
les interpréteurs, on ne peut pas entendre l'interprétation. We don't hear the interpretation to English. Natalie, I assigned you. Natalie, are you interpreting to English?
Est-ce que je peux continuer?
Just a second.
I'm interpreting. Hello?
Yes, we are not hearing the English interpretation.
Hello?
Yes, okay.
Yes, she is. I can hear it.
Okay, sorry. Then some people told me they didn't. Okay, then.
Can I just say, so in the call under the English French version, so you have to mute the original video if you want to listen to the English one. Otherwise, you will be hearing both of them at the same time. Thanks. Over.
Okay. All right. Thank you. Okay, on peut continuer.
Je pense, attendez un peu, à la 7e slide. Oui.
Yuta, we are in the 7th slide already.
The second one?
7th slide.
7e.
Oui, Georgette, tu peux continuer, s'il te plaît?
Ok, merci beaucoup, professeur. J'allais dire un mot sur...
So I was going to say talk about women's responsibility in general, but African women and the DRC women in particular, stay-at-home mothers are caring for members, they care for members of the family. And during this period of COVID-19, women are stressed because this burden is increased. Can we go to the 8th slide? Next. I was talking about the African woman, but women are stressed also. They are not excluded, you see. The African woman here and women in other places of the world, so that it is mistreated by children. We lost communication. Consequences of COVID-19. 40% of the burden of care it relies on the household. With the loss of revenues, household families do not go to health care facilities anymore, but because they do not have money, they are scared about the pandemic. There are several consequences. The increased morbidity and number of deaths, of mortality and morbidity, the use of grandma's revenues, the acceleration of self-medication, treatment based on rumors. So the country put in place an efficient system for intervention, and with obstacles such as wearing masks is mandatory, to wash hands, people have to stay home. I forgot to say that the municipality of Gombe, which is the center of the commercial hub of the DRC, was in lockdown since April 6th, and the country was declared as health crisis was declared by the President of the Republic since March 20th. So they've injected financial resources in health services to help the most vulnerable populations, and 4 to 5 health centers, local health centers, to manage pandemic cases and other cases as well. There's also the promotion of local capacities, acceleration of vocational training and activities. Now we are training women to help with the intervention campaign. The authorities are trying to create jobs and targeted jobs. They are talking about the post-pandemic period, and they are trying to see about a multi-sectoral approach adapted to our country, the DRC. There are also social economic impacts, consequences, and the DRC, 80% of household revenues are informal. The sources, they come from informal sources, small activities, trade, and women contribute significantly to the household revenues, gardening and trade. And the lockdown just eliminated these activities, and now households are severely impacted, and there's a food crisis and malnutrition. We see people asking for money, and within our family, people are calling us. So there is a crisis linked to the loss of income for households. There's also stress in the DRC, stress because of the loss of revenues, the lockdown, children are at home, husbands are at home. There's also the stress with regards to isolation. African woman does everything. They work together. They share joys and sadness together. But with the confinement, the African woman is isolated. If there's a death in the family is not next to her. Friends are not there because the government forced restricted gatherings to less than 20 people. So this affects women significantly. But there are mitigation. So authorities are trying to think to see how to support services with intensive agriculture, help community, and to support the most vulnerable and poor households with different levels of poverty. So the government is doing things, and there are organizations that are bringing food. Students are helping with, and orphanages also are being served. So the government is doing this effort. But women organizations are supported by the government. As I was saying, women in Africa, they live together. They do their hair together, and when they have children, or when there's a death in the family, they are always in a group. So now the African woman is isolated. They cultivate the fields together. They have death together. They celebrate life together and death together. So so now there's solidarity movements to reduce stress within households. We are mobilizing female personnel so they can join the intervention teams, and women organizations are raising awareness in marketplace and the street to tell women to calm down, not to be too stressed, and to to take care of household chores, because they have to ensure that children are homeschooled correctly, and women, pregnant women, they don't have enough money to go to health services, but they are afraid of infection. So women's organizations are talking so people can have their children in the appropriate services where they will be taken care of. And the woman, you can't forget that they are victims of violence. Everything is placed on the women's shoulder, and the DRC. Women always ask the woman, I need to eat, I need this, I need that. And with this pressure, the woman is experiencing stress culturally. People go back to natural treatments. We don't go to health establishments, but we use homemade remedies. There was a case where a family who lost 4 children because they use homemade remedies, but there are also positive things. Parents and children stay together. Now women, particularly women, spend a lot of time with children, and they talk about our origins and history of their culture, and children can ask questions because the mother is at home. So the African woman took back its place within the household, but also it went back to gardening, to being a seamstress and taking care of her hair, because now she cannot go spend children to salons, so she is doing herself the children's hair. So in the DRC, it's not a religious state, but religiously there's more spirituality between parents and children. So I'm going to show you new skills that I mentioned. Now, mandatory masks. Now, the country has declared that everybody has to wear masks, and so women's always like to be pretty and to dress well. They have these new prototypes and integrated with caps. So thank you very much. That's what I wanted to present. I'm sorry, I don't speak English. It's not my grandmother's language. I would not be able to be as eloquent as I am able to in my own language.
Merci beaucoup. Thank you so much, Georgette. I have some. I'm going to ask Jutta to show the results of the polling question before going into some questions and answers. So as you can see, the correct response was all of the above, and 76% of the participants who responding to the poll agreed that it is important to integrate gender in disease outbreaks, including the reasons that are mentioning here. So let's open for questions, and I'm going to go back a little bit to Dr. Klein. Dr. Klein, you have mentioned some of the important sort of when you talk about male bias, which is more male deaths and cases than females, that could be attributed to some of the male behavior. Some of our participants are asking whether or not comorbidities do play a role, and what role do they play?
Absolutely. So we don't know the precise role that comorbidities play, but having comorbidities is associated with a worse outcome from COVID-19. So having underlying conditions, including heart disease, hypertension, diabetes, obesity, have all been shown to be associated with worse outcomes and may contribute to the male bias that we see.
Thank you, Dr. Klein.
You're welcome.
So, Dr. Bagnol, you mentioned many recommendations. Could you sort of mention 2 or 3 more related to the psychosocial interventions that we could implement in some of African countries?
In relation to psychosocial intervention, I think that people have been mentioning that a lot of people in society, in different society, have been suffering anger, depression, have been suffering stress, have been suffering fear, and those aspects need to be dealt with. And there are different ways to deal with those problems. First, it's necessary to understand what is happening with the people. In many countries, maybe they are facing a lack of trust in the interventions that are being taken by the government. So involving different organizations, different civil society player can be a way to mitigate the kind of fear, the kind of stress that people are facing because they don't understand properly, they don't trust what is being done. So there is a broad level of communication that can be needed to sort out the stress that people and the depression that people are perceiving or feeling. Other issues are related to economical solution. So developing solution and giving possibility for people to recover as soon as possible and to see that they are not going to lose their jobs, their enterprise, their activity, and they are going to feed their family is also another way to sort out this kind of solution. And of course, a third intervention is to give people the possibility to have, once again, a telephone where they can call and they can discuss and they can find support. Working with local NGO who can give support, who can visit people, visit people who are living specific condition because they have people who are sick in their house, or because they have people who are unable or have a special condition, can also be a way to give some kind of relief or support in a situation of lockdown.
Thank you so much, Dr. Bagnol. I apologize to all the participants for the problems that we were having with the internet and with moving the slides ahead. I think that this is all of the time that we have for today, but we will continue with those discussions that are very interesting moving forward. We'll probably have more sessions on gender issues related to outbreak. So let me pass now to Dr. Mazet.
Yes, thank you all so much, and thank you for your wonderful presentations. Apologies for the technical difficulties today, but we are learning all of this together and navigating this together. So sorry for that and for going over, but we do thank the speakers, Professor Ndola, Prata, for all of the hard work, our whole One Health Workforce Next Generation team and Project ECHO. Perhaps William and I can just wave goodbye because we are over time.